So today we're going to have a brief overview of pulmonary hypertension. Please like and subscribe. So pulmonary hypertension is defined by the cardiac catheterization of the right heart as a mean pulmonary artery pressure greater than 20 millimeters of mercury at rest and a pulmonary vascular resistance greater than or equal to 3 Wood units. The classification is based on the severity and the etiology. Severity, mild, moderate and severe, 20 to 40, 40 to 55 and greater than 55 millimeters of mercury. The etiology is based on the underlying disease process and there's 5 subgroups. Disease of the pulmonary artery vasculature, disease of the left heart, disease of the lung, disease due to pulmonary artery obstruction, and finally those of multifactorial etiologies. The clinical features of pulmonary hypertension can be subtle. They are based on the interaction between the cardiorespiratory system. The symptoms relate to LV and RV dysfunction, so for example breathlessness and weight gain respectively. Intrathoracic mechanical symptoms, and these include dilatation of the pulmonary artery trunk, which can lead to compression of the left recurrent laryngeal nerve and thus hoarseness. And finally, symptoms of the underlying disease etiology. For example, upper airway disease, i.e. obstructive sleep apnea, chronic respiratory disease, COPD, and finally connective tissue disease, endocrine and metabolic disorders. The signs are those of RV failure, tricuspid valve regurgitation, and elevated pulmonary artery pressure. There's a selection of important investigations for the diagnosis of pulmonary hypertension. The gold standard is the pulmonary artery catheter to assess the pressure in the pulmonary artery. However, there's a range of surrogate markers. Those of the bedside, an ECG, looking at signs of right heart strain in the form of right bundle branch block, right axis deviation. Bloods looking at cardiac dysfunction in the form of BMP, and end organ dysfunction for U's and E's. Imaging would include a chest x-ray looking for dilated pulmonary arteries and right ventricular enlargement. And for an echocardiogram, there's a range of different parameters. Functional assessment looking for spirometry for obstructive or restrictive defects, and finally C-PET analysis. The pathophysiology is based on the underlying etiology, and as we've discussed, there's 5 subgroups. Disease of the pulmonary artery leading to pulmonary artery hypertension, disease of the left heart, disease of the lung, and also obstruction of the pulmonary artery, for example due to venous thromboembolism. And the 5th one is due to mixed unclear etiology. The mechanisms of anaesthesia is to maintain adequate normal physiological function. This can be achieved via a general anaesthetic or regional technique. However, nitrous oxide should be avoided. The management of acute pulmonary hypertension could be those of simple goals and additional agents. Simple measures would include maintaining normovolemia, low normal heart rate, sinus rhythm, preserving myocardial contractility, and avoiding significant increase in pulmonary vascular resistance, maintaining normothermia and normal pH. Additional agents can either reduce RV afterload, which could be due to inhalational or intravenous agents, for example prostanoids, and those which increase myocardial perfusion, which could be inotropic agents or vasopressors. It's important to prevent significant increases in PVR, pulmonary vascular resistance, and this can be achieved by preventing hypoxia, hypercapnia, acidosis, histamine and serotonin release, and significant increase in sympathetic response. Acute management of pulmonary hypertensive crisis is defined as an acute elevation of pulmonary vascular resistance whereby it overwhelms the ability of the RV to maintain cardiac output against an increase in afterload, and this is associated with significant mortality, and this will be managed as per acute pulmonary hypertension, which was discussed on an earlier slide. Chronic management of pulmonary artery hypertension occurs in specialist centres. This occurs when the mean pulmonary artery pressure is greater than 25 millimeters of mercury. They can be treated with a range of outpatient oral medications, and these include phosphodiesterase inhibitors, guanylyl cyclase activators, prostacyclin receptor agonists, and finally endothelin receptor antagonists. The complications of pulmonary hypertension are broad and are based on pulmonary infections, cardiac dysfunction, i.e. right heart failure, pericardial effusion and tamponade, vascular pathologies, which could be due to thrombosis, pulmonary artery dissection, alveolar hemorrhage, and pulmonary artery dilatation, and finally line-related complications.